Good evening, everybody, and welcome to this webinar broadcast from King Edward VII Hospital. And you'll know that the webinar is entitled King Edward VII Explains. And this evening, what we want to do is to talk to you in the audience about gynecological cancer. So I am accompanied by some fabulous speakers, and I know that you're going to share my enthusiasm about them when you hear them speak. My name's Leslie Regan. I'm a gynecologist and obstetrician at Imperial College London, and I'm also a trustee of King Edward VII Hospital. And you might wonder why they inveigled me to become a trustee, but I was very excited by their vision in the trustee board to think not just about gynecology and problems that women have, but about women's health right across the life course. I feel very strongly that women need to be part of the problem and the solution, and that when we inform women about what they can do to help themselves, when we get them more involved in identifying symptoms and signs that may be suggesting that they're running into trouble, for example, areas of gynecological cancer, which is the topic of tonight, then everybody benefits from that. I think it's going to be really an exciting webinar, and I'm really looking forward to talking about it. But as I said, I'm particularly impressed by the fact that King Edward VII has got this real focus on women's health right across the life course, because women do have very predictable needs in terms of their general health, screening, and then also sorting out their problems when they develop something like a gynecological cancer. So this is really very important, and we know that all of the individuals who have signed up to this platform tonight have got an interest in finding out about it. As I've already said, I think you'll find our speakers really well informed and very generous in the way that they are able to talk to patients. And I hope that you will feel at the end of this webinar that you've really learned something about what King Edward VII can offer you as a potential patient. So we're going to have 4 presentations. Firstly, we're going to speak to a patient who's had lived experience of the problem, and then we're going to speak to 3 of our experts who work at King Edward VII. And then we're going to have a lengthy discussion. Half an hour has been reserved for discussions from the audience. So please may I ask you in the audience to put your questions into the chat, and myself and Barney will try and ensure that as many questions as possible are answered during the discussion point. Now, I'm going to start now by introducing Sam Middleton, who has been a patient quite recently. She's a patient of one of our speakers, Professor Christina Fotopoulou, and she's very kindly agreed to come and share some of her experiences with us this evening. So I'd like to start, Sam, by firstly welcoming you back to King Edward VII, and also to pay a tribute to your bravery, because it's not easy to talk about these things. And I know how emotionally traumatic living with these diagnoses and going through the treatments and recovery period have been. So thank you on behalf of all of us, both the speakers, the hospital, and the audience, for being so brave to share that. Now, Sam, I believe that you were diagnosed with ovarian cancer in October last year. So let's start to, perhaps you can start by sharing with us, how old were you when you had that diagnosis, and how did it come to be? What prompted you to go and see a doctor? Or perhaps you didn't see a doctor, perhaps you spoke to a friend, but just tell us your story at the beginning.
Okay, thank you, Leslie. Thank you for being so kind. So I was 47, and in August of last year, I developed tummy and lower back pain. The tummy pain was unusual in that it was a sharp stabbing pain in the lower left side of my tummy. I booked an appointment with my doctor. We were mid-pandemic, so it was, of course, a phone call. It wasn't a physical appointment. Although I didn't have typical urinary infection symptoms, we agreed that that was most likely what it was. She prescribed me antibiotics, and I dropped off a urine sample. I didn't hear anything because you don't hear anything if there isn't a problem, but I still had the symptoms. I went back to the doctor, all over the phone, of course, and we repeated the same process. Nothing showed up and I didn't hear anything. So weeks went by and I was really uncomfortable. I was walking around, I was working from home, but I was walking around with a with a hot water bottle, basically. And I developed this urgency to pee. So I would be on video calls with work, and I would desperately need the toilet. It was really uncomfortable. So I went back to the doctor. And to be honest with you, I felt like I was making a pest of myself, but I knew something wasn't right, and I wasn't going to go away. So my doctor sent me for a bladder scan, and I went for the bladder scan. And I'll be honest with you, I could tell from the unspoken behavior as they were scanning me that something was seriously wrong. And I was told that my ovaries were very, very enlarged. He looked very concerned. Obviously, it was very, it was scary. And he sent me for an urgent blood test, a CA125, a cancer marker blood test. Those results came back very quickly, and my CA125 was sky high. And I had gone for the scan on the Wednesday, and I was in Christina's office by the Friday evening.
So I'm glad you ended up in Christina's office, because I think that's where I might want to be if I had that similar experience. But tell us what happened then. So what did Christina say to you, and how did you go forward?
So Christina obviously discussed my medical history with me first and foremost. I had, interestingly, I'd had an endometrial ablation earlier that year. So I'd had very recent scans and nothing had come up as unusual. She examined me, and I remember her pointing out how swollen my abdomen was. Looking back with hindsight, I think that I had felt bloated, but like a lot of people, I put on weight during lockdown, and I didn't really think any more of that. Christina was, I mean, Christina, she was massively impressive from the get-go. She's obviously absolutely at the top of her game. She's fabulous. And she was very direct in saying to me that it did look like it was ovarian cancer. But obviously I needed an MRI and a CT scan to be sure. So I went for the scans, and I remember Christina calling me. She FaceTimed me with the results, and things were a little bit blurry. You can imagine that it was kind of my worst fears, anyone's worst fears. She confirmed that I had cancer, and that in a matter of weeks I was actually going to be having very major surgery, and that would be followed by chemotherapy. So I mean, it was mind-blowing. My head span, I felt sick, I was terrified. And the weird thing is I had felt, I obviously had tummy pains, but other than that, I had felt well. I'd been walking, I'd been going around living life, looking fine. Other than the tummy pains, I was living a normal life. But anyway, I was.
You went in for your surgery.
I did.
It was quite extensive surgery.
And so
you won't remember the surgery because I'm sure you were asleep, but what are your memories of the recovery period? Because I think that's what our audience would like to hear about.
Yeah. So, I mean, I spent 5 days in an ICU. I was in King Edward VII, and I was 5 days in an ICU. I was had amazing care. Christina would kind of come and visit or FaceTime me. I was in hospital, I think, for a total of almost 10 days. And again, it's quite strange going from somebody that's walking around completely normal to somebody that can't move about freely, etc. When I went home, I basically moved from the sofa to the, from the bed to the sofa. I would nap. I was, I was a different person. I remember Christina said to me that I had to keep mobile, and I would wait until it was dark and I'd shuffle around the block to try to get back my physical fitness. I was on a really restricted diet for quite some time. That was harsh, but it was absolutely essential. I have to be honest, recovering from the surgery was probably the thing that was hardest. I was a fit, relatively young woman, and physically, I had to recover. It was tough. But by the beginning of December, so I had my surgery early November. By the beginning of December, I was starting chemotherapy.
And I think often what patients forget is when you're having major surgery and it takes some hours to perform the operation, that you're asleep for all that time. And it's quite a shock to the system to put your whole nervous system to sleep and then wake it up again. And I think that's often something that we forget to tell patients about, that they're going to have consequences from that. It's not just the physical assault, it's the fact that they've had this lengthy anesthetic as well. So you've obviously done incredibly well. So you then went on, I think, to have chemotherapy. And I think there are a couple of points about the chemotherapy that you were going to share with us, the cold cap and the hair business. And so if you could tell us what you feel prepared to share, that I think would be really helpful for the people.
Yeah, of course. So my chemotherapy, I was kind of prescribed with 6 rounds of chemotherapy. My oncologist, who is also fabulous, offered me, because I was obviously worried about losing my hair, like a lot of people would be, I was offered the cold cap, and I was offered to have one drug, the Taxol drug weekly in lower doses. And I went for that. It meant that I had actually 18 sessions of chemotherapy rather than 6. But I was very lucky. The cold cap worked for me. It's not pleasant. It's like having a migraine. I would advise anyone that's considering it that the first 15 to 20 minutes is the hardest. If you can get through that, you can do it. And I was very lucky. I managed to keep my hair. The chemotherapy, so I used to call every 3 weeks, I would have what I referred to as a big blast, which I basically had 3 drugs all at once, and it would knock me sideways completely. And I think we all in our head have an idea of what chemotherapy would be like. You know, it's not nice. On those big blasts, I would kind of go into a black hole, and everything would feel a bit hopeless, and I'd always be relieved when I came out on the other side. But anyway, one thing I should say is I didn't work after the surgery. I have a full-time job and I didn't work, and I gave myself that time off to focus on my recovery. But by the end of chemo, I actually started back at work on my last week of chemo. And I went back to work on a very gradual, phased return. For me, it was a milestone in terms of returning to normality. You know, I'd been in this sort of very intense, everything had been very focused on the cancer and my recovery, and I wanted to return to normal. And something that was quite nice is that we were just coming out of the lockdown then. So things were opening up and my chemo had finished, and sort of that felt positive.
So it's like going from suspended animation back to near normality.
Exactly.
And you've obviously done really well, Sam. So what's happening to you now?
So I'm on maintenance treatment. So I have I still go into the clinic. I go into the LOC once every 3 weeks, and I have a drug called Avastin, which is an IV drug. And I'm also on something called PARP inhibitors. So they're tablets that I take every day. I remember Christina said to me, probably just after the surgery, she said it would take a year, maybe 9 months to a year to feel normal again, like, and she was absolutely right. It is almost a year. And I do have side effects from the drugs, I should say. So I have things like joint pain in my ankles, and I'm tired. I sleep like a teenager. But otherwise, I am, I would say, back to normal. I don't think you're ever completely the same after cancer. It changes you. But I'm just carrying on with life and enjoying life.
Well, thank you. And thank you for being so generous and so brave in sharing your story with us this evening. And I know that I'm speaking for everybody on the platform to say how delighted we are about your recovery and how well you're looking. So absolutely fabulous. And a great tribute to my colleague Christina's endeavours.
To the entire team at King Edward.
Yes. So that's lovely. So thank you very much indeed. And I think what you've demonstrated as well to our audience is that you don't go and see one doctor to get your gynecological cancer fixed. You have to be part of a team, or rather you have to hopefully join a team that's going to look after all sorts of parts of your life: the surgery, the anaesthetic, the recovery period, getting better, and all of those things, and then starting the chemotherapy, and then the maintenance, as you've just described. You're still going in every 3 weeks. So this is a journey, and I congratulate you, and you've made a great journey there. I'm going to move on now to invite my colleague, Dr. Joseph Yazbek, to talk about it. And Joseph's a consultant gynecologist at King Edward's, the 7th, and also at Imperial College. And he's particularly interested in revolutionizing the pathways and improving the pathways of managing women with suspected gynecological cancers, and particularly interested in using minimally invasive surgery and advanced ultrasound and other investigative techniques. So Joseph, thank you so much for being with us this evening, and the floor is yours, as they say.
Thanks, Leslie. Well, I've been asked to talk to you about the forms of gynecological cancers and symptoms, and whether we can screen for these cancers and how do we detect them earlier. In the UK, we deal with 5 cancers, or I'd say 6 cancers, but we don't do breast cancer like Europeans. Most gynecologists will treat breast cancer. So I'll call these cancers. We start from the ovaries and tubes, so that they are classified as one cancer. We have the womb cancer, and this could involve something called endometrial cancer. And we have other tumors called sarcomas in the womb. Of course, there are other types of cancers that could be related to pregnancy and placenta, and they are in the womb as well. Moving downward, I'd say there is the neck of the womb cancer, or cervical cancer, to vaginal cancer and vulval cancer, or the vaginal skin cancer. So obviously, the location of these cancers will have different symptoms. And unfortunately, the disease that is called the silent killer, the ovarian cancer, does not have symptoms that present early. We know that women, when they present with the symptoms of bloating, of pressure on other organs such as bladder irritation, difficulties going to the toilet, difficulty in swallowing, it means this disease is probably spread inside the abdomen, and they are due to increased abdominal pressure and, of course, involvement of other organs. Some types of ovarian cancers have hormonal functions, so these women present with irregular bleeding or lack of periods. And to classify these types of ovarian tumors, we have 2 types. We call them epithelial, which is the most common cancer that is affecting women, or we call it serous cancer mainly. And there is non-epithelial cancers, of which the hormonal producing cancers are there. There are subtypes of what we call an ovarian malignancy called borderline tumor. This is not a true cancer, although it does have abnormal cells and it affects women at young age. It can affect their fertility potential. Hence, it's so important to recognize such a disease, because we could treat it properly and we could offer these women the chance of preserving their fertility, or at least to have the family completed before they go for more definitive treatment. If I go to screening in the context of organ by organ, we know from various studies that we can screen for ovarian cancer. The problem is, what are we trying to detect? And the most successful screening program is the cervical screening program, because it goes after pre-malignant lesions. So we look at cells that could be abnormal, and if we left them untreated, they could become cancer. The problem with ovarian cancer, when we detect it on ultrasound or on MRI, it's already a cancer. So we cannot find a disease or a lesion that, if we leave it in place, may develop into cancer. It could be argued that if we look at women and scan them regularly and find lots of cysts and take these cysts out, we may prevent cancer like the Europeans do, but this could be at a very high cost of surgical complications, doing lots of surgeries to probably not improve the mortality, so death from this disease, or improve the survival of these women. There has been 2 studies in the UK dealing with screening recently. It's called the UK FOX and UK CTOX. One looked at women with family history of cancer and the other at general population. Both of them managed to screen, managed to detect cancer. Unfortunately, most of the disease that was picked up was again picked up at stage 3, which is the problem with ovarian cancer. So it's advanced stage, and hence the requirement for such an extensive surgery like the one that Sam had. Moving down into the womb, the most common cancer that women, gynecological cancer that women have in the UK is called endometrial cancer. It's the lining of the womb cancer. And fortunately, and I'd say no cancer is fortunate, but these diseases present with bleeding. It mainly happens after the menopause. Women don't have bleeding for more than a year. Suddenly they have postmenopausal bleeding. And actually, 95% of women who have bleeding don't have cancer, which is a good thing. Although I see women coming to clinic with postmenopausal bleeding thinking that they have cancer, all of them. The good thing is only 5% may have this disease. And the majority of these patients will present at a very early stage. So it presents early, contrary to ovarian cancer, which presents late. And hence we can treat it much quicker, and the cure rate is very high in endometrial cancer. There's no point of screening the general population, because we'll have to do lots and lots of scans. We may have to do lots of operation to basically prevent or to lower the mortality from the disease. I'll be very quick to move to cervical cancer, which used to be a very huge problem in women before the cervical screening program started. And luckily, the cervical screening program, meaning smear tests, have managed to reduce or actually significantly improve the disease detection and mortality from this disease by approximately 80%. And recently we started doing human papillomavirus testing, which is HPV testing. And this, on top of that, it improved the detection rate by a further 80%. So we are really good at detecting pre-cancerous lesions in the cervix. We go and treat them early, and hence we have much better survival from this disease compared to countries that do not screen for cervical cancer. Symptoms of cervical cancer are very commonly seen in young patients with irregular bleeding, but there are more alarming symptoms such as continuous discharge that is blood-stained, bleeding following sexual intercourse that is persistent, and of course, feeling a mass in the cervix. Talking about vaginal and vulval cancer, vaginal cancer is rare, I'd say, but it follows a similar path to vulval cancer, given the nature of it. And unfortunately, when this disease is identified, it's usually quite advanced, because it doesn't present with much symptoms. There may be bleeding, there may be pain during sexual intercourse, or they may be discharged. Again, there's no screening here. And vulval cancer, which is the most obvious cancer that could be detected and could be screened for, is unfortunately unscreened for. We see women in clinic with a very big vulval cancer and you ask her, when did you notice this lump? And she said, I didn't see it probably 2 or 3 weeks ago. Obviously, these women do not look at their vulva. And I don't know whether this is something that is not supposed to happen, but there is no screening for vulval cancer, although it is not the most common gynecological cancer, but it is so easy to screen for such a thing and find a lump early in there. But there are pre-malignant conditions in the vulva that could also be screened for. And obviously the symptoms are those of irritation symptoms such as itching, burning, pain, and bleeding. So this is briefly the types of gynecological cancer and the symptoms and the screening.
So a whistle-stop tour through the reproductive tract. So thank you for that. I mean, I just wonder if you'd like to make a comment though, Joseph, about the, my understanding there's been a bit of an epidemic in endometrial cancers or womb cancers, which is secondary to obesity. And I think that would be useful to bring out. And also wearing my sort of policy hat, both nationally and internationally, I'm very conscious of the fact it's really important that we don't become complacent about cervical cancer screening, because there's been a 20-year all-time low in uptake of cervical cancer screening in the UK, and that was before the pandemic. We haven't got any figures now for the pandemic. So just a couple of comments, because you know, we've heard about Sam, and fortunately Sam developed symptoms and was able to be seen and treated very quickly. But you know, what about the obesity factor, and what about screening for cancer?
So it is an epidemic or a pandemic, obesity, and it goes with lifestyle changes, with sedentary lifestyle, lack of exercise, and the more obese patients are, they are more at risk of actually not only endometrial cancer but other cancers, including ovarian and womb. But womb cancer is directly related to obesity, and a simple way to explain that is the fat that is under the skin produces a hormone called estrogen, which is like estrogen, but it's a bad estrogen. It thickens the lining of the womb, and these women will present with endometrial cancer. So you almost always see patients with endometrial cancer who are usually overweight. I am not saying it's a disease of obese patients, but actually this doesn't help it, especially in women who have diabetes. They don't exercise much and they do not look after their diet. Regarding the cervical screening, of course, I mean, it was a huge progress made in the last 20, 30 years with cervical screening program. And the figures of regular screening, those women who've screened regularly every 3 years, at least, as per the NHS guidance, they've managed to reduce the risk of developing cancer. And the COVID pandemic has been a bit of a problem, because for approximately a year, there was a bit of a reluctance to go to have a cervical screen. The GP was busy to do such a thing. But I think now most women are invited back to have the cervical smear. It is provided throughout the NHS, and hopefully this will continue to be. It's very important for those who had the vaccine, and for you, if you have children and they had the HPV vaccine, they have to have regular screening. The vaccine does not stop cancer. It does prevent abnormal cells, and the way to know there are abnormal cells is by doing cervical smears.
So 2 important messages there then, you know, get your daughters HPV vaccinated at the earliest possible age, and make sure that you do have your cervical smears. And I'll just share with our audience that, again, wearing my global hats, it's very interesting. The thing that was most worrying about women's health globally was the number of women that died in childbirth or during pregnancy and postpartum in the first year of their baby's life. And there'll be about 300,000 women in our world this year who will die of maternal mortality. This year is the first year in history where the deaths from cervical cancer will exceed that. And when you think about the fact that this is potentially a preventable disease, that's really something for everyone to think about. So we must never be complacent about screening for cervical cancer, because it's a preventable disease, and we have 2 tools, the HPV vaccine for young girls and also a screening for the older women. Now I'm going to move on to Alan Farthing. Alan Farthing, who's a consultant gynecologist who specialises in complex surgery, and he's a very, very experienced laparoscopic or keyhole surgeon, and has pioneered been one of the main pioneers in using this to treat cancer patients in the UK and also to try and preserve fertility. So he's head of department at the Gynaecological Cancer Centre at Imperial College, where he's based, and we are colleagues. And he's also director of clinical strategy at King Edward VII. So, Alan, I think you're going to talk to us a little bit about discussing the tests and investigations needed in diagnosis. Thank you so much for being here.
Thank you very much, and to everybody for tuning in. Yes, my role is to pick up the pieces as the next step in the process, I think. So thank you, Sam, for your very eloquent and moving story of your own experience. Joseph's talked more about the background of the different types of cancers. My role is to talk a little bit, hopefully reasonably briefly, about what might happen if somebody actually thinks you might have a gynecological cancer. So if you feel that you have the symptoms that might represent a cancer, or you present to your GP and your GP thinks that the symptoms you've got might represent a gynecological cancer, then what next? What would happen to you in order to get to that point where a diagnosis is made? And I just want to pick one thing out of what Joseph said to emphasize to people that when they go to their GP and their GP says, you have the symptoms that make me worried you might have a gynecological cancer, I'm going to refer you in urgently to the NHS clinic or to a private gynecologist who I trust will be able to look after you. Even in those circumstances, you've got a 1 in 20 chance that you do actually have a gynecological cancer. So you've got a 19 out of 20 chance that you don't have a gynecological cancer. So that's a statistic Joseph mentioned in his talk. I just wanted to pick up on that and emphasize it. But you would usually be referred in to an expert clinic in order for an appropriate examination and appropriate investigations to be done. And of course, it rather depends on what symptoms somebody might have as to what particular examination and investigations may be done. One of the commonest symptoms is postmenopausal bleeding, and what we want to do in those circumstances is exclude a cervical cancer or an endometrial cancer. And an examination of the cervix, possibly taking a smear test or taking a biopsy from the cervix, is something that is not usually a particularly uncomfortable investigation to undergo in the clinic for most ladies, and isn't something that most ladies should be particularly scared of, and is something that can be reasonably definitive in being able to exclude that possibility. The scan that would normally be done under those circumstances would be an ultrasound scan, often performed by somebody like Joseph Yazbek, as he's a particular expert in doing this sort of thing. And the lining of the uterus would be looked at to see whether it's in any way thickened and whether it looks like the type of lining that a biopsy ought to be taken from. And that would often be followed through with a biopsy, which can sometimes be taken in the clinic. That does sometimes tend to be a little more uncomfortable than just a straightforward examination. A hysteroscopy, which is where we put a telescope inside the uterus in order to have a look and to take a biopsy, is another investigation. There is an increasing trend, certainly in the NHS, to try to do that investigation without a general anaesthetic if possible, but a general anaesthetic is preferred by many people, as that investigation, particularly in older ladies, can be quite uncomfortable. But that would be fairly definitive at letting us know that the lining of the uterus and the cervix is normal, and we can reassure somebody, or if necessary, make the appropriate arrangements to treat something. The other way that, as with SAM, people may present is with abdominal symptoms. And under those circumstances, an examination, of course, may well be useful, but isn't always useful, and isn't always something that GPs are particularly keen on doing. But an ultrasound scan can be useful, as it was in Sam's case, in order to determine that the ovaries look normal or don't, depending on what gets seen. Sometimes an ultrasound is enough to be able to give us sufficient clues to be able to treat the lump that might be discovered as one that is suspicious of a cancer, or to be able to reassure us that a big cyst sitting on an ovary looks entirely benign. Other tests that may get done would be an MRI scan, which is a little more involved than an ultrasound scan, a bit noisy to sit inside the MRI scanner. Some people get a little claustrophobic inside the MRI scanner, and it tends to involve you having to lie pretty still for about 45 minutes or so. So that's an investigation that, in fairness, most people are able to tolerate fairly well, but isn't easy for everyone. CT scan takes much less time and is a little bit easier and not anywhere near as claustrophobic, and does give us a really good picture of all of the pelvis, abdomen, and the chest, so that we can look at the extent of abnormality, or make sure that we're happy that there isn't an abnormality of any other sort going on at the same time. And a CT scan isn't necessarily the best way of looking at the organs in the pelvis, especially if they're normal, or especially if the abnormality in the pelvis is normal. I just want to round off my little bit by saying that, having had all those tests, investigations, examinations, suspicions, or whatever, then anybody's management is usually discussed by something we refer to as the multidisciplinary team. That these days has become a very important part of the process. We as surgeons discuss the management or the proposed management of a patient with our colleagues. It means that there is a consistency of how we recommend patients are treated. It gives us the reassurance that we haven't missed something, and that our colleagues are able to help us out if they think there's an investigation that we haven't yet included. And it allows us to plan for the treatment and have the entire team know what the purpose of that treatment is, because most people will, during their journey, talk to multiple members of the team, as Sam has already mentioned. And for us all to be on the same page, understand what we're trying to achieve and what we might have to do to a patient in order to achieve that is quite useful. And the multidisciplinary team meetings are a very good way of coordinating all of that. I'm going to stop at that point, Leslie, if that's all right.
Yes, thank you very much. That's lovely. And so I think what our audience is picking up is that there are a lot of people involved in this journey and in this process, some of whom you will meet, as Sam has shared with us, but some of them you won't be meeting. You probably won't meet all the imaging radiologists that report the scan and use years and years of expertise at looking at images to give advice to people like Joseph and Alan and Christina about where they think the extent of the disease is. And you probably won't see the pathologists who look at it under the microscope after the surgery's been done. And then, as Alan was saying, what's really crucial is the MDT, the multidisciplinary team meeting. And after you've had your surgery, that histology report will come back to the MDT and everyone will talk about it and then review the histology, so that everyone in the team can be sure that you're getting the very best advice, not just one person's thoughts that day, possibly they're having an off day, but everybody's advice on how's the best way to go forward. Now, I'm just going to encourage our audience to please put any questions they've got into the chat or into the Q&A session. Otherwise, I'll be having to talk to myself for the end of the webinar, which you won't really want to do. And I'm going to ask you again, please put the questions in the chat, and also ask our speakers and Sam to think of any other things they would like to raise. And then I'm going to turn to Professor Christina Fatopoulou, who is a consultant gynecological oncologist working at King Edward VII Hospital and also Imperial. And at Imperial, she's the principal investigator of the Ovarian Cancer Action Research Centre UK. And I'm delighted that she's also the clinical director of women's health at King Edward VII Hospital and helping us to move that hospital through to understanding that women's health is all part of a life course. So Christina, thank you so much for coming. We've already been introduced to one of your very appreciative patients, and I think you're going to talk about decision-making factors, possibly one of the most difficult things that all three of you have to do in your work as a gynae cancer expert. Making decisions, because decisions, of course, aren't usually black and white. They're usually very dependent on an individual situation and an individual woman, in the case of gynecological cancers, particular concerns and worries. So, Christine, over to you.
Thank you very much, Leslie. Thank you for this webinar today, and especially many thanks to Sam. It's amazing for me to see her not as a patient, but as a very glamorous woman here in this chat box. So I'm very proud of her. So sorry for my voice. I have a little cold. So I remember when I was a child in Athens, and my father was a professor of surgery, and he was treating cancer patients. He would tell me that actually, when we have a cancer patient, we don't really tell them they have cancer so that they don't get upset. We just go and treat them. And then we give them chemotherapy just to make the wound healing a bit better without telling them they have cancer. This is how many, not us anymore, but many decades ago, some doctors in some countries and some cultures, and you still see it in some cultures, that it's not really allowed to say to the patient, God, you have cancer and we need to do things, so that you don't scare them. That's, of course, completely outdated, and not just outdated, but we know nowadays that the patient is not just important to know what's happening, but the patient, and I will talk about women, but also, of course, it applies to men, they need to be involved in any decision-making processes. We can't anymore, and we shouldn't, as doctors, just say, hey, that's what I think you should do. I just plan you for surgery next week, come on that day, and we operate. This is not happening anymore. What we know as professionals ethically, but also from the GMC and from all the national and international guidelines, is that the patient is the one who drives this. Our obligation is to inform her about the available treatment options, the sensible treatment options, of course, that have been discussed in an MDT. But an MDT, as Alan said, is not just to say black and white, that's the road, but it's to say what the imaging is, what the options are, and then to discuss with the patient what are the available paths. And then the patient will decide with you and the team what is the best for her. Because whatever fits the one patient doesn't fit everybody. And it depends not just on the age and the comorbidities of the patient, but also on the soul and on the mental capacity and on the wishes and how far a patient wants to go, and what are the thresholds and risks and benefits that she would accept. So currently what we're doing is that when we have a patient with a clear diagnosis of ovarian cancer, as confirmed by the MDT, as confirmed by the imaging, we discuss with CC together the gynecologist, but then also the medical oncologist, the clinical nurse specialist, very important, and discuss with her the risks and benefits of different approaches. For example, in a primary ovarian cancer patient, we will discuss whether to operate in the beginning or to just give chemotherapy first and then operate later. We discuss the risks and benefits of what this involves. There are some patients who even want to know what happens if you don't do anything. And this is something that I always discuss with them. So doing nothing, yeah. And this is something that especially elderly patients, multimorbid patients might want to have. And then after having discussed everything, either the patient feels very strongly about one way or the other, and then you just make your next steps. Or what I very often prefer to do is to give them a few days of thinking, especially when it's not a clear-cut decision, and then discuss with them again and then plan the next steps. So it is key that the patients are driving this, and they are our co-players in this. They are practically, this is a fight, yeah, and we need the patients always on our side to be able to win this. Otherwise, it's not possible. And single decisions are not accepted anymore. but they're not winning. So we know that the patients, by having them involved in a very active way, these patients, they will do better just because they know how to fight better. It's easier to face the enemy in the eyes and look at the enemy in the eyes. You always you win. You have high chances of winning. So in terms of the operation, there are the operations currently, they have changed massively compared to how we're used to do them in the past. Even though they are more extensive, especially for advanced disease, they are potentially even less traumatic than they used to be in the past, just by new technology, by new instruments, by new ways of dissecting the tissue. We have enhanced recovery programs, so we have the patients, they will sit on the chair outside of the bed, if possible even on the same day after the operation. Not like in the past, where they would wait till the patient passes flatus till they are able to drink or eat again. So we have changed a lot the way we approach the patients, and we're also very lucky within the European Society of Gynaecology and the BGCS to issue some guidelines about the perioperative recovery and how we should, within an enhanced recovery process, manage those patients even better so that they recover even faster. We know from quality of life studies after extensive surgery that, as Sam said, it takes approximately 9 months not to go to the same status like you were before the operation, but to a better one. So higher than before, because before the operation, as Sam said, you're not okay, you have symptoms, you feel bad. The question is how much it needs so that you are like before everything happened, and that's approximately 9 months. We have managed to render many diseases chronic. So of course we have an early stage endometrial cancer, very early stage ovarian, very early stage cervical cancer. They have very high cure rates. But even now, patients with advanced diseases, we can treat them very effectively so that they live years and they have a long journey, as you said, Leslie, a journey of years ahead of them, even if the cure is not very high. So it's not just about cure, it's about managing the disease and having, as Sam said, a good quality of life and being back to normal and walking, and even with a maintenance drug. So we have changed a lot the way we treat and manage the patient, but also the way that we see this disease. I don't want to talk longer because I see that we have some questions already.
Thank you. So really important point, Christina, and also emphasizing the fact that it isn't black and white, and often what we're doing in the 21st century now is helping patients to understand how to live with their cancer and keep it at bay, even if it's there in the background.
Yeah.
We've got several questions about whether womb cancer or uterine cancer is hereditary. And one of our audience is saying, my mother died of womb cancer, so I do worry sometimes that it could possibly happen to me. So to which of our 3 panelists would like to answer that question?
Shall I go ahead and answer?
Yeah. Start, Joseph, and then I'll going to too.
I mean, quite a few cancers are inherited. Fortunately, most cancers are not. And it's sad that they happen because we are unlucky, I think, more than anything else. But there are forms of womb cancer that could be inherited. And we are talking here about a syndrome called Lynch syndrome. So this is a genetic disorder that unfortunately is passed from mother to daughter or to her son as well, and it is passed as an autosomal dominant inheritance. So 50% of children may get the disease or the genetic abnormality. This is a syndrome that could be the cause of endometrial cancer or womb cancer. It affects women. I'd say the type of cancer comes early, so before the menopause, compared to the usual endometrial cancer that we see. They're not different histological types, so they're still the same histology. They still have a good prognosis, if I put it this way. So the outcome is usually very good with these cancers, but they do affect women at a younger age. And the giveaway sign is that these women are usually not overweight. So we talked about obesity earlier. We always worry about a young patient presenting with a precancerous condition called complex atypical hyperplasia when they're very thin and there is no polycystic ovarian syndrome. we always worry about Lynch syndrome. So how, yes, it could be inherited in 50% of cases. Does it cause cancer? Not necessarily, but it could, in up to 60% actually of cases, cause womb cancer. It is responsible for other cancers, including stomach or colorectal cancers, as well as ovarian cancer in about 7% of cases. You could, of course, women who know about this type of cancer in their family, they could probably attend for regular screening. I don't think that this will identify a precancerous lesion, but it could help if you see a polyp or anything else. Not more than once yearly. Regarding to how do we detect it now, the indicators, luckily in our cancer center, we do test every patient with endometrial cancer. We do something called DNA mismatch repair. So we test for the possible malformation in the DNA that could suggest such a syndrome. So yes, every patient who has endometrial cancer will do that. In the private sector, we almost always offer it to our patients. So we say, look, shall we test for that? Because it does have also implications on treatment as well, not only on preventing bowel cancer or stomach cancer, but it can have implication on treatment.
So to simplify for our audience, there is a syndrome called Lynch syndrome, and the prevalence is about what? About 1 in 200 women, is that correct?
Yeah, it's not very much, yeah.
And that this is important. It tends to be in rather younger women, women who perhaps who are not overweight, and it's important because it may be the precursor of tumours of other organs. So that's an important one to identify. Another question about following a finding of endometrial adenocarcinoma after a hysterectomy, what, if any, tests could be undertaken as a follow-up? Alan or Christina, would you like to answer that?
I can pick that one up. Christina, you've turned your microphone on as well. I don't mind. But I mean, can I just say one more thing to follow on from Joseph's answer on the previous one, Leslie? So the number of gynecological cancers that are actually inherited, it remains very small. So if there is somebody in the audience who is worried that they are at increased risk of getting an endometrial cancer because their mother had an endometrial cancer, the chances would be extremely small. And we're getting better at understanding things, but it should be a reassuring tone that we put out there. In terms of when somebody has an endometrial cancer and they have it treated, that would normally involve a hysterectomy, sometimes involves extra treatment as well, but ideally not. And under those circumstances, somebody has an extremely high chance of being cured, as Joseph has said earlier. We tend to follow people up by bringing them back to the clinic. Excluding the COVID pandemic, we would bring them back to the clinic and we would usually have a conversation with them, because actually you gain quite a lot by having a conversation with people during their follow-up, and somebody may have 1 or 2 worries that they're not sure whether to mention, and it gives us the responsibility of determining whether we do anything about those worries and investigate any further. And then almost invariably with an endometrial cancer, we do a vaginal examination. And the reason for that is if there is ever a problem with an endometrial cancer, subsequently, if there is a return of the cancer, then the most common place that it does return is the top of the vagina. And if we can pick that up fairly early, then we can often rescue the patient and give them second-line treatment and still cure them at that stage. So that's what tends to happen.
That's really
if I may add, so that's exactly as Alan said. So what an extra small point. So there are many different protocols of follow-up across the different countries. And also the teams that do it. For example, medical oncologists would usually just chat. The gynaecologists, they would examine. In Europe, we do at every a follow-up appointment and ultrasound, so it's varying. What, however, is the new trend is the PIFUs. This is the so-called patient-initiated follow-up, which is now the new trend internationally, not just due to the pandemic, but because we have done studies and we have seen that actually it is relatively safe or safe for many of the gynecological cancers. And we have even within the British Gynaecological Cancer Society issued a guidance for that. For example, patients with a very early endometrial cancer who have a very low possibility risk of relapsing, we now tend to go away from just seeing them every 3 months in clinic, but we just can tell them to call us, to have a direct access to us or to a nurse if they have bleeding or whatever. So this is something that will increasingly more come. We have we were forced to test it abruptly during the pandemic because many of the consultations now are on Zoom or FaceTime. But the PIFU is something that internationally will happen more and more.
Thank you, Christina, and thank you, Alan, and thank you, Joseph. So there's another question here about, can we talk about the treatment for low-grade ovarian cancer? So early detected at stage 1 or stage 2?
So low-grade ovarian cancer does not always necessarily gets diagnosed early. Low-grade ovarian cancers can also be diagnosed in advanced stages. We know that the treatment, so in the past we used to put everything in one basket, high-grade, low-grade, and treat the same way. Now we know that the chemotherapy response rates of low-grade ovarian cancer is less. It's not zero, it's around 20%, whereas in a high-grade would be around 80%. Surgery is something that plays a role very much, but at some point these patients will relapse again and won't be able to have surgery again. We have new drugs that are currently keeping the disease at bay. For example, Sam talked about the PARP inhibitors for high grade. This is not something that we would, for example, give in low grade. This is something, we have the MEK inhibitors, we have anti-hormonal treatments. Low grades are hormonally active tumors, so we treat them sometimes like a breast cancer with tamoxifen, with letrozole. We nowadays in all the ovarian cancer studies, we have stopped putting them together with a high grade. So we have separate studies just for low grade disease. So there is a lot of movement also there.
Great, thank you. And there's a question also directed to you, Christina, about the treatment and prognosis of ovarian granulosa cancer.
Yeah, granulosal tumors are not really epithelial tumors. They are sex cord stroma tumors, so they come not from the epithelium, but if you want to say from the inner part of the ovary. These patients, what tends to happen with these tumors is that they live decades, they have an excellent prognosis. However, granulosa cell tumors, if they come back again, they keep coming back. And the interesting thing is that they may come back after a decade, 5, 10 years, and then come back 5 years later. So what happens is that they come after many, many years, and then the intervals usually tend to become smaller. It is a disease that is being treated mainly surgically. We have done many studies that have shown that you can actually operate those patients sometimes 5, 6 times. Chemotherapy is not something, we used to give chemotherapy a lot for granulosa cell tumors. Now we're stepping back from it, and we're giving it only in the more advanced later relapses where we can't really operate. So we now would treat with anti-hormonal treatment like the low-grade tumors and with surgery. But the prognosis is in generally a very long-term prognosis, a very long prognosis.
Thank you. Well, I hope our audience are all appreciating the fact that all of our speakers are being very upbeat, as is our patient, Sam. And I just thought it'd be interesting to ask you to comment a little bit about how things have changed. I mean, what's very evident to me is my mother and my grandmother's age, if they had ovarian or endometrial cancer, there would be one operation, there'd be one drug, or there'd be one bout of radiotherapy or whatever. And what's coming out of this conversation, and I think everybody will be realizing, is that it isn't one size fits all. As we now understand that all of these tumors are very, very different individuals, and they need individual treatment. So I wonder if each of you just take a moment as we finish off to look in your crystal ball and think about the future and what do you see coming. We're in the middle of a genomics revolution. I always say to my patients, I mean, I don't think I understand half of it, but I know it's very, very exciting, and it's opening masses and masses of doors. So let's starting with Joseph and then moving on to Alan and then Christina. What do you see as the future with the genomics that's available to us, with this individualized treatment? Leave our audience on an upbeat note about how great it's going to be.
Well, obviously one would hope that both these genomics and all the new advances in treatment will change the way we treat cancer, because currently we haven't made much progress. I mean, we are actually doing quite well with survival. Patients don't die of the disease. Once we diagnose them, there are lots of different types of chemotherapy. There are the PARP inhibitors in Christina's field in ovarian cancer. Actually, all this will hopefully change the way we treat women. Do we still need to do big surgery? The hope is that we will have a diagnostic method, that's my dream, of telling early that there is something wrong, that we can treat it too early, because we know that early detection is the most important thing in diagnosing cancer and in treating cancer, because once we diagnose early, we could have an easy ride in the treatment. But of course, if this could be married up with new treatment methods that will avoid the toxicity of chemotherapy, that would be the best. So yes, we are hopeful. There's lots of research in this field, both in diagnostics and actually in treatment.
Lovely. Alan, your thoughts for the future?
So I'd like to say there's an awful lot has happened in the recent past, in that it almost beggars belief that only 20 years ago people could present with a gynecological cancer and see their local gynecologist and not necessarily a cancer expert. That's changed dramatically. Everybody gets treated by a proper cancer expert these days, and that's made a big difference to how people have been treated and how they've been treated as individuals with their different types of tumors and small variations that exist. We were a bit blunderbuss. We still are sometimes. You cut it out, you blast it with radiotherapy, or you kill it off with chemotherapy, to use certain terminology. And that still remains the mainstay of many treatments. But with the improvement in our understanding of the genetic abnormalities that you can have, not necessarily the inherited genetic abnormalities, but the abnormalities that occur inside individual cells that have gone wrong, with our understanding of that, drugs have been developed that can actually be specifically aimed at those cells. Sometimes still killing them off, but sometimes actually just keeping them under control. And as Christina mentioned previously, turning a disease that would otherwise rapidly cause somebody's demise into a disease that they can live with for many, many years and live symptom-free for a long time. That's, I think, where we're heading next. Obviously, the ideal scenario is manage to cure everybody one day, but I think we'll get there in a number of steps.
Yeah, but you make a really important point, because, when I was a medical student, everybody dealt with everything in the gynecological world, and we didn't have special cancer hubs. And I also remember, Alan, and you will too, the big fight that we had at Imperial trying to make a central cancer hub, but we got there. And it's been a benefit to many, many, many thousands of women since that time. Christina, your last thoughts about a look to the future.
Yeah, so as Alan and Joseph have said, I mean, there has been a massive progress in the gynecological cancers in the last years, and not just progress, but also awareness. In the past, everybody would make research and would make leaflets and marathon running for breast cancer, which is a very common disease, but nobody would even know what ovarian cancer is, just because it's a rare disease. That's not the case anymore. People are much more aware, the patients are more aware, the GPs are more aware. And so even for cancers that in the past we wouldn't use to know anymore, and that's why we used to call them silent killers. Yeah, and I hope this is a term that at some point will go away. So the future will be that we will go increasingly more and more away from chemotherapy. We have currently targeted agents in form of tablets, like Sam said, in form of the ADCs. These are the adjuvant drug conjugates that you actually just give the drug inside the cell that goes into the cancer cell. So all these are, there are even ovarian cancer studies where there is not even a chemotherapy arm anymore, just new targeted agent versus another new targeted agent. So I think the future will be at some point that these cytotoxic treatments will be largely replaced by new approaches. I think the surgery is, the surgery is something that is indeed a failure of early diagnosis. Yeah, no discussion about that. If we reach a point where we will be able to diagnose cancers early, then yeah, we won't even need to cut them out anymore or to treat them. But still, till we reach that point, it's important that we try to make our surgeries more traumatic, more sustainable for the patient, and that everything is being treated within a team. Yeah, we have gone far away anymore from one individual saying what needs to be done and the patient just follows. Yeah, we are teams, specialized teams. There are centers of excellence for ovarian cancers, and this is where the future is going.
Thank you. So for our audience, things are getting better and better, and the genomics will help us with that more as we now understand more and more about the character and the individuality of these tumors. And as Christina said, you know, we used to drip in poisons, and now we're actually targeting the actual organs and sparing the rest of the body from those side effects. So I think it's everyone can feel upbeat about the fact that we're making progress. So it's now 20:36, so I've gone 6 minutes over my target time, so I'll probably get my knuckles wrapped. But I just wanted to say once again, Sam, thank you so much for coming and sharing your story with us. It was very brave of you, and I'm sure that all of our audience have really enjoyed it, and I've greatly enjoyed meeting you. So thank you to our three fabulous panelists, Joseph and Alan and Christina. I personally, as a woman in her middle 60s, feel very lucky that I've got them around if I need their help in the future. So thank you also to Barney and the King Edward VII Hospital staff for setting up these webinars. And I hope the audience will agree that they're enormously helpful to help you to understand more about these very common problems and how you can go about helping them. And first and foremost, I suppose, well, rather lastly, I should say, not first and foremost, it's so important that women have information with which they can make their own decisions. And that's one of the main purposes of having these webinars, so that you become more informed about what you need to do to help with your own health. And I hope that you will join us again in the future for other webinars on different topics in women's health. So thank you everybody for being with us tonight. It's been a pleasure talking to you all, and I very much hope that we'll see you again on this platform. Thank you. Bye-bye.
Thank you very much. Thank you. Bye.
Bye-bye.